Hi, my name is Dr. Eleasa Sokolski. I'm an assistant professor of internal medicine and psychiatry at Oregon Health and Science University. I primarily work as a consultant on our inpatient addiction medicine service, and today I'll be talking about methamphetamine and psychosis. I have no financial disclosures, and after today's talk, you'll be able to identify the difference between primary and substance-induced psychosis, describe the mechanism by which methamphetamine use leads to psychosis, explore the ethics of involuntary commitment for patients with substance-induced psychosis, and also discuss how substance-induced psychosis impacts use of the insanity defense in legal cases. But I want to start us off with some definitions and to really dive into what is psychosis, because I think the term is used to describe a number of different mental health conditions, but psychosis itself is more of an umbrella term or a syndrome rather than a specific illness or disorder. Psychosis is made up of both positive and negative symptoms, and those positive symptoms can be things like delusions, hallucinations, disorganized or bizarre behaviors, or disorganized thinking. Negative symptoms are things like decreased emotional expression, like someone not having as much facial expression while they're speaking, low motivation, lack of spontaneous speech or poverty of speech, a lack of pleasure or interest in activities, a decreased focus and attention in activities as well, and then also a withdrawal from social interactions and social situations. When someone's coming into the hospital with a first episode of psychosis, they've never been diagnosed before, the differential diagnosis or the number of potential things that could be causing that psychosis is very broad. And it's important to think about all of these different possibilities if someone is coming in for the first time. They've never been diagnosed with psychosis before. That syndrome of psychosis could be caused by an underlying mental health condition, such as schizophrenia or another schizophrenia spectrum disorder. It could be a mood disorder, like bipolar disorder or major depressive disorder with psychotic features. And then substance-induced psychosis, which we'll be doing a deeper dive on today, is another possibility as well, along with other mental health conditions like post-traumatic stress disorder, personality disorders, or physical health conditions, such as an infection like HIV or syphilis, a brain tumor, or an autoimmune disease. So I think these are all very important to consider. If we look just at substances that may cause psychosis, there are many, many substances that can lead to this syndrome. I think about with alcohol, benzodiazepine, or barbiturates, particularly with withdrawal syndromes, people can develop auditory hallucinations or visual hallucinations. Cannabis intoxication or use of synthetic cannabinoids can lead to psychosis. Stimulants, which will be our focus today, can lead to psychosis. Dissociatives like ketamine, dextromethorphan, PCP, opioid use, including kratom, which has opioid and stimulant-like effects. Stimulant-like effects can lead to a syndrome of psychosis. Cathinones, better known as bath salts and MDMA, are on that list as well, and hallucinogens like LSD and psilocybin. Now diving into what is methamphetamine. So methamphetamine is an amphetamine derivative that's used worldwide. And as you can see here, the unique thing about methamphetamine is it has this little methyl group that's attached onto the side that's in that green box. That methyl group makes the molecule more lipophilic, which means it can pass through lipid barriers much easier than amphetamine can, allowing it to better penetrate the blood-brain barrier compared with amphetamine. So this means it gets into the brain much easier and much quicker. And when we look at the epidemiology of methamphetamine use in the US, this is data from the National Survey on Drug Use and Health from 2015 to 2018. During that time, 1.6 million US adults reported using methamphetamine in the past year. And over a quarter of those who reported methamphetamine use were using on 200 plus days that year. So a huge portion of people were using daily or almost daily. The highest rates were among men aged 35 to 49. And about a third, almost a third of those people who reported methamphetamine use also had a co-occurring serious mental illness. So we see this really high degree of overlap between serious mental illness and methamphetamine use. And that's consistent with data based on also in the National Survey on Drug Use and Health, just looking at the overlap in general between any mental illness, serious mental illness, and substance use disorders in the US. And as you can see, there's just this very, very high degree of overlap. If we just look at serious mental illness and substance use disorders, in 2021, 6.4 million people in the US had both a substance use disorder and a serious mental illness. And we know that substance use can lead to poor outcomes in people with serious mental illness, such as schizophrenia. For example, up to 50% of people with schizophrenia have a co-occurring substance use disorder that excludes nicotine or tobacco use. About 34% of people have an alcohol use disorder that's co-occurring with schizophrenia, and 28% have a co-occurring drug use disorder. And then up to 70 to 90% of individuals with schizophrenia have nicotine or tobacco use disorders as well. So a huge, huge overlap. And moderate to heavy use of substances is associated with poorer outcomes, including psychosis, depression, and poor quality of life. If we look at overdose mortality, there's been an enormous amount of focus about overdose from synthetic opioids, such as fentanyl, but we're also seeing rising rates of stimulant-related overdoses in the US. And in 2021, there were over 33,000 overdose deaths from stimulants alone. But what this graph here points out is that this is not equal across racial and ethnic backgrounds. That we're really seeing these highest rates of accidental overdoses from non-Hispanic, American Indian, and Alaska Native populations. There's a huge discrepancy in who's dying of overdoses from stimulants. So now that we've gone over the background information, I want to dive into how do we tell what is driving psychosis? If someone's coming in with psychosis, how do we know if it's an underlying mental health disorder such as schizophrenia or a mood disorder, or if this is substance induced? And the long and short of it is that it can be really, really difficult to tease this out. I always try to assess the temporal relationship. What is the timing? What came first? Was it the substance use, or was there a mental health disorder or symptoms of a mental health disorder that developed before someone began using a substance? This is often easier said than done. There may not be a sufficient period of time of abstinence where someone has not been able to use a substance. And if you're basing this off of a clinical interview with a patient, they may not be able to remember or may have poor recall. I think it's really important if there is a period of time where someone has been in a controlled setting, like in the hospital, or even periods of incarceration in jail or prison, where they're less likely to have access to substances. If they're still having symptoms of psychosis during that time period, that can be incredibly helpful information. Also, if someone is coming in repeatedly, for example, to the emergency room and testing positive on urine drug testing, and every single time they're experiencing psychosis, they're positive for substance use, that can also point more towards a substance-induced psychosis. If you're doing a clinical evaluation and you have the ability to get collateral information or additional information from family or other close contacts from that person, that can also be very helpful to give a timeline to try to determine what came first, the substance use or the psychosis. But I do want to acknowledge that often I feel like I'm in this situation, and this can be really challenging. Sometimes if I can get a really clear timeline, I can say this has really been driven by the substance use, or it seems like there really was a mental health problem first before the substance use began. But sometimes we're not able to figure it out based on the information we have available. So what actually happens when someone uses methamphetamine? There's different routes of administration, but for example, if someone smokes methamphetamine, it's rapidly absorbed by the lungs very, very quickly through the alveoli of the lungs, and it reaches the brain within 6 to 8 seconds. This is one of the reasons why smoking methamphetamine is one of the more common routes of administration, is that it is very rapidly distributed, and the peak effect occurs within minutes after smoking. IV administration is actually a little bit slower than smoking. So if someone is injecting methamphetamine, the peak brain uptake time is about 4 to 7 minutes after injection. And then for people who are using it intranasally or swallowing it, using it orally, there's a much slower onset of effect. Usually takes about 30 to 45 minutes before it reaches its full effect in the brain. And then once methamphetamine gets to the brain, it has a number of effects, but really the primary one is the massive release of excitatory neurotransmitters, including dopamine. And so what methamphetamine does is it acts at a couple different dopamine transporters in the brain. And you can see this top picture here. There's these little green transporters at the nerve terminals. These are responsible for packaging up our dopamine into these nice synaptic vesicles where they're stored and bringing it back into the synapse, into the nerve terminal, and making sure it's all nice and stored and packaged up. But when those red triangles come in, methamphetamine comes in, it reverses the action of both the vesicular monoamine transporter 2, which is responsible for nicely packaging up dopamine, and the dopamine transporter, which is what brings dopamine back into the nerve terminal. It reverses both of those, and dopamine just gets flooded into the synapse, into the nerve terminals. And it floods into different parts of the brain, including the nucleus accumbens, which is the center that's implicated in addiction and the reward pathway. But that release happens throughout the brain. We also see a release of other neurotransmitters, including glutamate and norepinephrine. And glutamate is an excitatory neurotransmitter that's been implicated. Dysregulation of the glutamate system is one of the leading theories to why people develop schizophrenia as a neurodevelopmental disorder. And so it's really interesting that we see that same dysregulation with repeated methamphetamine use, that there's a breakdown in that pathway, a dysregulation of that pathway of glutamate release. And that there's a lot of parallels there that we'll talk about in a little bit more detail. But before we kind of dive into the chronic neurologic effects, what happens acutely when someone uses methamphetamine? So people can develop anxiety, irritability, panic symptoms. People can become paranoid. They could have those symptoms of psychosis, tactile hallucinations, or that feeling like there's bugs crawling on my skin, repetitive behaviors, and this can even be things like skin picking, which can be fairly common. Someone who uses methamphetamine regularly might have wounds or sores on their skin from that repetitive skin picking, restlessness, agitation, tremor, and then there's some physical signs that you could see on a clinical exam, like an increased heart rate, dilation of the pupils, sweating, and nausea, and that's because of that flood of those excitatory neurotransmitters. In severe cases, this can present as a little bit more seriously, or a lot more seriously, things like stroke, seizure, heart attacks, or arrhythmias, or abnormal rhythms of the heart. But with repeated use of methamphetamine, there's some particular changes that can occur in the brain, and we actually do see structural changes in the brain. We see decreased levels of dopamine receptors and transporters. So those get downregulated. Our dopamine system doesn't work as well when we have those massive floods of dopamine occurring regularly at our nerve terminals. We also see decreased blood flow to the prefrontal cortex, which is the frontal part of the brain that's responsible for higher level decision-making and planning. Methamphetamine itself has multiple direct neurotoxic effects in the brain, including oxidative stress, mitochondrial injury, direct nerve cell death, and degeneration of the nerve terminals, and also breakdown of the blood-brain barrier. And then we also see dysregulation of the immune system. And so we see the creation of this pro-inflammatory state in the brain. And that's interesting because we actually also see something similar in people who develop schizophrenia. So similarly to schizophrenia, chronic methamphetamine use can lead to cognitive impairment, including executive dysfunction or trouble with decision-making and planning, and also deficits in verbal and working memory. Studies have documented similarities between methamphetamine-induced neurotoxicity and traumatic brain injury. So people may present similarly to people who have had a TBI. And there's also a direct increased risk of hemorrhagic stroke among methamphetamine users, both because the blood vessels get more leaky and because of the increase in blood pressure when people use methamphetamine. So as I mentioned earlier, repeated use of methamphetamine can lead to dysregulation of a number of neurotransmitters in the brain. Both the release of dopamine is implicated in the development of psychosis, but when we see excessive glutamate release as well, that's one of the other excitatory neurotransmitters, that can lead to dysregulation of a number of systems that keep our bodies and our brains keep our brains from developing psychosis. And as I mentioned earlier as well, that follows a really similar pathway to one of the leading theories of how people develop schizophrenia. So based on that, it's not surprising to see that psychosis with chronic methamphetamine use is incredibly common. And actually, among people who recreationally use amphetamines, over 75% of people will develop transient psychotic symptoms at some point in their course. And so I've really come to think that with stimulant use, especially highly potent stimulants like methamphetamine, it's an expected effect for someone to at some point develop symptoms of psychosis. Up to 36% of people who misuse methamphetamines, however, will go on to develop psychosis that lasts beyond the period of intoxication. So when someone uses methamphetamine, the effects last for maybe at most 24 hours, 36 hours, and then people will clear the methamphetamine from their system. They'll no longer be experiencing those acute effects. But some people have a persistence of psychosis. For most people, that gets better within a week. But there's a small subset, estimated to be somewhere between 16 and 20%, 26% of chronic users of methamphetamine who have symptoms that will last even longer, and they develop this chronic psychosis picture. This question arises of how do we think about this subgroup? Are these people who have developed schizophrenia because they have a persistent psychosis without substance use, or is there something else going on? And there's a couple different competing theories here. And there's a lot of literature that's emerging, particularly out of Japan, around chronic methamphetamine psychosis as a different explanation for why people have this persistence of psychosis even after they've stopped using methamphetamine. There's really not enough evidence at this point to say that these are two separate clinical pictures, but I think it's worth exploring for a few reasons. One group that says these are people who have used methamphetamine that's caused psychosis and it's unmasked schizophrenia, that this was someone who is at risk for developing schizophrenia, and now the use of methamphetamine has pushed them over into meeting the clinical criteria for that diagnosis. And the alternative theory of this being a chronic methamphetamine psychosis says this is really a parallel pathway. There's this other process that's going on in the brain, almost like an acquired form of schizophrenia, that it's leading to these similar processes of neurotransmitter dysregulation, and that's leading to the psychosis. And I think there's a couple different reasons why it's important to think about this, and why it's important to consider that these might be two separate clinical diagnoses. The first is that this provides some direction in treatment. For example, someone with schizophrenia really does need long-term treatment in most cases with antipsychotic medications, versus someone with chronic methamphetamine psychosis may not need treatment beyond the period of psychosis that they experience. They may require treatment initially, and then if their psychosis resolves, they're no longer using methamphetamine, several months have gone by and they're doing really well. That might be someone I feel more comfortable trialing off of medication. The other implication is that this differentiation may be important in interactions with the legal system in terms of implications for involuntary treatment and forensic evaluations, which we'll explore in more detail in just a minute. But before I go into that, I do want to highlight that this way of thinking about psychosis from substance use is different than when we think about psychosis from cannabis. There is more evidence to support for cannabis use in particular that cannabis is an independent risk factor for developing schizophrenia, and in particular cannabis use in adolescence, that leads to dysregulations in neurodevelopment early on, and then people later on develop schizophrenia. There seems to be more evidence for a cause and effect scenario with people who use cannabis at a young age. Whereas with methamphetamine use, there's more mounting evidence to support that this may be a separate clinical scenario called chronic methamphetamine psychosis. But before moving into the legal implications, I do want to highlight a few things. One is that effective treatments exist. I think that a lot of this talk has felt a little bit doom and gloom about these horrible neurologic effects, but people can get better. While there are no current FDA-approved medications for stimulant use disorder, there are very effective behavioral therapies, and in particular, contingency management. Contingency management programs ask patients to alter their decision-making around substance use, where they shift away from the immediate reward of using a substance to a delayed reward. And that's often either like a prize or a voucher that they get for participating in a desired behavior. And that could be showing up to an appointment. That could be submitting a negative urine drug test. And they get rewarded for that behavior. And there's a lot of evidence to support contingency management across a variety of substance use disorders. And studies have shown that contingency management can reduce stimulant use and reduce mental health symptoms like anxiety, depression, and psychosis in people with serious mental illness. So it's an effective therapy, and it's effective for people who have serious mental illness. And when we look at the prognosis, while there are some patients that experience prolonged psychotic symptoms lasting for months and years, and there are high rates of returning to use of methamphetamine, I do want to highlight that the course of recovery is not always linear. Often people return to use multiple times before achieving a longer period of abstinence. And there's a lot of good evidence to support that people can have cognitive recovery. That cognitive impairment that people get with chronic methamphetamine use can improve with abstinence. And in particular, I want to highlight that there was a study of 358 methamphetamine users. They looked at scores on a Montreal cognitive assessment tool, or the MoCA, and they showed that people who initially scored in ranges of mild cognitive impairment, similar to what we would expect with early dementia, had a recovery to normal scores after 2 years without methamphetamine use. So it took a long time. It took 2 years of abstinence for people to get that cognitive recovery, but people were able to recover into the normal range. Also, when we look at MRI scans, there's been a study looking at MRIs of people who have been abstinent from methamphetamine for 8 months, showing that while they initially had a decrease in their gray matter volume, they were able to recover some of that gray matter volume loss at 8 months. And so again, 8 months is a long period of time, but those studies showed that people can recover not just the functional impairments, but also some of the structural changes that we see in the brain with chronic methamphetamine use. So I think there is a lot of hope with treatment. So I've just told you that patients with persistent psychosis after chronic methamphetamine use can recover, but that it can take a really long time. It could be months to years for people to really see that full recovery. And I also told you that the return to use is high, that people often require multiple attempts at treatment before they're finally able to gain longer term recovery. So a question that comes up a lot is the role of involuntary commitment. When someone is using methamphetamine chronically, they're cognitively impaired. Is this someone who should be in a controlled environment? And I just want to highlight, this is a report that was put together by the Legislative Analysis and Public Policy Association in 2019 that looked at involuntary commitment for substance use disorder laws across the US. At the time of this report, there were 35 states and the District of Columbia that had enacted involuntary commitment laws for those suffering with either alcohol use disorder or other substance use disorders. And there's a lot of variability in the laws across the US. And I encourage you to look into the laws in your own particular state. Where I'm currently working in Oregon, our laws specifically state that you cannot involuntarily commit someone, particularly for a substance use disorder, that those people are excluded from involuntary commitment. And there are some similarities. Most of the laws require that someone is a danger to themselves or others, or they're gravely disabled, or they lack decision-making capacity, they can't manage their personal affairs or care for their basic needs, or that they've had some kind of loss of control over their addiction, which is part of the definition of having an addiction. So this is something that the majority of states in the US have laws around this. But I want to highlight the ethical scenario that comes up with involuntary commitment. These are the 5 primary ethical principles in medicine. And often the idea of involuntarily committing someone pins these different ethical principles against one another. For example, patient autonomy, the patient's right to make their own treatment decisions and choices, can be very challenging in treating patients with substance use disorder because using that substance might impair their decision-making process. If someone has cognitive impairment, as much as I want to honor their autonomy, that might be difficult to do if they aren't able to make decisions for themselves. And then there's beneficence, where we have the moral obligation to act in the benefit of the patient. That can come into conflict with autonomy if what's in the best interest for the patient doesn't align with what they want. Non-malfeasance or doing no harm can be a challenge because, for example, involuntary psychiatric hospitalization, while sometimes necessary, can be harmful. People can find those experiences very traumatic. When it comes to justice, distributing goods equitably across society, treating patients with the same conditions equally. When we know that mental health and substance use disorder care is not equally distributed across the US, and that, for example, Black, Indigenous, and people of color are less likely to have access to medications to treat substance use disorders, and insurance may limit treatment options for patients. And then fidelity around truthful and transparent communication and confidentiality. Often we're breaching confidentiality if we're sending someone to the hospital, for example, with suicidal ideation. So this is incredibly complicated when it comes to treating substance use disorders or considering involuntary commitment. And I often feel like this. I feel like this is like my chicken or the egg picture, where this is very complicated. And I think hopefully will trigger some discussion. But I do want to highlight just a few more points around involuntary commitment and the challenges that come up around the ethics of this. I do want to say that with civil commitment for substance use disorder treatment, while there's a lot of uncertainty about what might be best, there really is a big lack of data and efficacy around civil commitment in the US. There's not a lot of data saying that, or really limited data saying that putting someone in the hospital, forcing them into treatment leads to better outcomes. It's kind of a real lack of knowing whether that's something that actually helps people. And there's some evidence that might cause harm. So, for example, if someone is civilly committed to substance use disorder treatment, there's no guarantee that they're going to be treated with a standard of care, that they're going to be offered FDA approved or indicated medications. And in particular, if we look at disorders like opioid use disorder, there is data showing higher rates of overdose and death when people are released from mandatory treatment, including one study that showed that overdoses were 2.2 times higher among people who were treated involuntarily compared to voluntarily for opioid use disorder. So there is a lot of potential for harm. There's a limited lack of certainty around whether involuntary treatment is beneficial. So I think it's important to discuss and think about and learn about the laws in your state, and consider the benefits versus harms around involuntary treatment. The other place that I really see the interface between methamphetamine associated psychosis and the legal system is around the use of the insanity defense and forensic evaluations. So the insanity defense, which is based off of the McNaughton rule, is this idea that if someone has a mental health disorder and they commit a crime and they're not able to recognize that what they did was wrong, or they weren't in control of their behavior around the time that they committed that crime, they can say that, they can opt for the legal insanity defense, or that might be recommended by their legal counsel, to say that this is not someone who is able to understand what they were doing, or that what they were doing was wrong because of their underlying mental health disorder. That being said, pretty much across the board, substance intoxication and withdrawal are excluded from people claiming the insanity defense, because the act of consuming substances, if that impairs decision-making, that process is considered voluntary, which I could talk about how, all the potential problems with thinking about it that way, and addiction as being a mental health disorder, and that not all substance use is always voluntary as well. But legally, substance intoxication and withdrawal are generally excluded. And then there's this idea of settled insanity that I'd like to talk about. So this is the idea that allows for longer-term impairment resulting from substance use. And really the population that I think about this applying to is, what about people who have chronic lingering psychosis after using methamphetamine, or that chronic methamphetamine-associated psychosis? That's someone who might benefit from a settled insanity claim. So this is based off of a case from 1986, the People versus Skinner, and it set up these 4 criteria for determining settled insanity. So for someone to use this as a legal defense, their mental illness must be fixed and stable. So someone has to have persistent psychosis, for example, as a result of substance use. It must last for a reasonable period of time. It has to extend past the duration of the effects of the substance that they were using. And it has to meet that jurisdiction's legal definition of insanity. And so currently, this is not recognized in all jurisdictions, but there's 29 states and the District of Columbia that have accepted settled insanity on the basis of the insanity defense. Only one state, Colorado, has explicitly rejected it. So this is something that if someone commits a crime while experiencing persistent psychosis as a result of prior substance use, and they're in a state where this is accepted as a potential legal defense, they may consider pursuing. And to highlight this, I just want to go over one case. This was a case from Texas from 2013, Sprouse versus Thaler, in which a man was accused of murdering a customer at a gas station and the police officer who responded to the scene. And during the capital murder trial and the following appeals process, the defendant underwent multiple forensic mental health evaluations. So multiple different people evaluated this person. There's a lot of variability in the assessments that ranged from the defendant having schizophrenia to not having psychosis at all, to having a lingering psychosis from chronic methamphetamine use. And ultimately, in the appeals process, the defendant claimed he had been inadequately represented due to his counsel not raising this settled insanity defense. And the court replied to him that given the options, his counsel could have reasonably chosen to focus on the schizophrenia diagnosis, to downplay his own responsibility in his brain damage through extensive drug use. But they didn't, and ultimately he was found guilty and sentenced to death and received the lethal injection in 2015. And there's a paper written about this case by Andrew Breisner and Jennifer Peel. And one of the things they highlighted was, how do we think about these laws? If we're using the insanity defense, how do we think about how the law interacts with the underlying cause or origins of a mental disease? Because for this person who ultimately received a lethal injection, the court told him, well, if your counsel had focused more on the schizophrenia, maybe you would have qualified for this defense. Maybe this would have been acceptable. But should it matter if the underlying cause of someone's psychosis is a chronic mental health disorder such as schizophrenia, chronic substance use, or some other thing like a genetic disorder, use of a prescription medication? Should this matter? Because this was someone who, there was this argument made that they were not in control. They did not understand what was going on around the time that they committed this crime. But because they focused on one potential explanation over another, ultimately he was not able to use an insanity defense. And I think it raises a lot of questions. There's a lot of different ways to think about this. But I think there's a strong case for methamphetamine-associated psychosis as being considered a mental disease. And really, we think about these chronic problems related to substance use as existing as a separate entity from mental health disorders. And I'd encourage you to think about whether or not we should be siloing them in that way, or whether we should be thinking about them under a broader umbrella of mental health disorders. So I know I crammed a lot of information into 30 minutes, but if there are 4 things I hope you take away from this talk, they're as follows. The first is that psychosis associated with methamphetamine use is extremely common, with over a third of patients experiencing persistent symptoms after resolution of methamphetamine intoxication and withdrawal. Chronic use of methamphetamine is neurotoxic. It can lead to structural brain changes that can cause psychosis and cognitive impairment. I also want to highlight that cognitive impairment can improve over time, but it can take months to years to see those improvements after someone stops using methamphetamine. It can also be very difficult to differentiate chronic methamphetamine psychosis from a primary psychotic disorder such as schizophrenia. And there's a lot of debate over whether chronic methamphetamine psychosis should be considered a separate entity or fall under the umbrella of schizophrenia. I find it helpful to try to differentiate the two because doing so can be helpful to guide treatment. And it might also have implications in civil commitment determinations if substance use related diagnoses are excluded from civil commitment, and also forensic evaluations for people who are claiming the insanity defense. And also patients who are experiencing symptoms of psychosis or serious mental illness can benefit from behavioral treatments for stimulant use disorder, including contingency management. Thank you so much for attending my talk, and I appreciate questions and discussion that arises.